Hi, everyone, and welcome to episode 25 of the HCBiz show. Today, we're talking a very important topic in chronic care management. The numbers speak loud and clear. Back in 2010, AHRQ estimated that we spent as a nation about 86% of our healthcare dollars managing patients with one or more chronic conditions, it didn't go down, much to when you added conditions. So 2 or more conditions still accounted for 71% of the spend across the entire country. With that, it's a clear problem for the large payers, for CMS, and they have been trying to attack that with some new CPT codes going back in January 1st, 2015. And that's what we're going to talk about here today. So as always, I have my co-host Shahid Shah here with us. Welcome, sir.
Hi.
And joining us from ChronicCareIQ, that's a vendor working in this space, is Matt Ethington. How you doing, Matt? Thanks for joining us.
Thank you. Hello. Happy to be here.
And we have one more guest feverishly trying to install Chrome right now to join us, Dr. Scott Miscovich, coming at us from the great state of Hawaii. And he is working with Matt in his practice, and he is also working on CPC Plus. Hawaii was just announced as one of the regions selected to participate in that pilot for the next 5 years. So hopefully we'll get into that, talk about how CCM, what is CCM, how it sets up, how it plays into the other models like ACO and CBC Plus that are coming online. So that's where I'd like to get started. Matt, did you want to give a quick intro for yourself and just let the crowd know who you are and where you're coming from and how you came to know about all of this stuff?
Sure. Well, thank you. So, the company ChronicCareIQ is a chronic disease management platform for private practices that they can use, and it automates compliance while proactively engaging patient updates on healthcare. It derived out of my experience with hundreds of practices, automating their office electronic medical records, and also my experience as a chronic patient with type 1 diabetics at age 30. So we knew we had to make something that was easy to use for the practice, and I know from my own experience it had to be very easy to do for the patient. I think we achieved that with results, making it successful for practice.
All right, I apologize, Matt. You're a little okay. You're coming a little choppy for both of us. Your fears have been realized. You're chopping as you're talking. There, we didn't make most of that out.
I tell you what,
might be good to put on the earphones.
Yeah, give that a whirl.
So while Matt puts that up, what I wanted to do was to reintroduce the topic. We've talked about chronic care management a couple of times this year as part of our episodes. And really, there's no question that CMS, broadly speaking, and the industry at large wants to move into chronic care management for population health in general. The question has been why the chronic care management code itself and many of the other programs have not seen the uptake that CMS was expecting. So what we're hoping to do is, as we do each week, is focus on the business of healthcare by allowing some of our startups and innovators like Matt himself. So Matt was talking a little while ago. He's one of those guys with well over a decade and a half of experience working with hundreds of physicians, getting things like revenue cycle management, electronic health records, and those installations, usage, support, as a sales guy as well as on the implementation side. So he's seen the problems firsthand, knows what kind of issues practices go through. And so one thing, maybe a good place to start with, as we have our doctor from Hawaii joining us shortly as well, is let's talk broadly speaking about population health and how much do those physicians that you're working with, Matt, really care about population health? I mean, is it us in the talking heads community and the thought leadership world and writers and speakers and that kind of stuff just really talking about this? And the poor guys that are out there trying to make a living seeing patients and working every day don't really care about this stuff? Or is it as important to them as we seem to think it is, or CMS wants it to be? So maybe that's a good place to start. And then we can follow up that question by saying, what's keeping CCM and other codes from being more broadly used? Is it a technology problem? Is it a workforce and training problem? Where is it? So number one, Matt, just tell us, is the move towards value-based care and population health real? And if it is, then why is it so hard to move these initiatives along?
Yeah, can everybody hear me a little better now?
Much better.
Okay, great. So first, the mission is real. It has to be real, right? We're on an unsustainable course, but we face the challenge of a particularly rocky EMR rollout. So at this point, I think a lot of physicians look at this rather more idealistically than practical. And it's going to take some time, I think, to restore some trust and get something practical in the market that can be used without a gargantuan effort that demonstratively brings about better care. We made a lot of promises around getting better ROIs with electronic medical records and speeding doctors up instead of slowing them down. And so I think when the proof is in the pudding, doctors at the end of the day are still rational consumers and they'll move quickly. But we've got some work to do as a vendor community to deliver solid metrics.
And so do you think that, so it sounds like, so as you're talking to, and even putting your EHR sales guy hat on, are they talking about the same things that we are talking about in the community? Or are they seeing population health and value-based care and these kind of things in a different light, so that our innovators and the folks that are in the startup community and trying to build tools, how should they be talking to these physicians in the same way that you read about? Or, when you go in, they're talking to you guys about different things and you have to kind of like bring them back into the population health and value-based reimbursement world?
So that's a great question, Shahid, and it happens two different ways. Like on the top-down approaches, where we're working with the large health systems to help them plan and help them implement, and they're very serious about their missions, and they talk about population health and patient engagement, and managing health in their communities. Now, but from the bottom up, when you're involved with the independent practices, the more rural communities, the smaller groups, you're talking specifically about benefits to the individual patient and benefits to the doctor's bottom line without having the staff, have a mutiny. And so it's practical from the bottom up, but it is very, how do we do this system wide from the top down? So it's the bigger words at the top down, and it's the real life experience from the bottom up. Okay, yeah, that's a good way to look at it. And then when with respect to looking at your initial rollout, that you guys are luckily as a startup, you've actually been able to move pretty quickly, I think, because of your past experience knowing what not to say to these folks who want to buy technology. So what do you think has been successful for you getting them to say yes to your technologies, and what remains a struggle? And then Don will pick up on the specifics about the solution and what ChronicCareIQ is.
Perfect.
Oh, so boy, there's a lot of ways to go with the answer to that question, Shahid. What's been successful for us is reaching out specifically to smaller practices, to getting them to engage, to use the system, showing it works, and kind of going into the back door through the health system. What is now proving, starting to be successful, but it took a long time to get here, is that top-down approach where you're presenting the idea, you're presenting the platform, but hospitals and health systems aren't necessarily risk-reward environments. So that has been, they're waiting to see it first. And so that has been more of a challenge. They want to see something work.
Right. No, and that makes a lot of sense. So summarizing it for our audience, and Charisse mentioned he liked what you said about the ideal versus practical sense. So it sounds like that the idealism you can continue to try to push from the top, but focus on practicality and what you can do for them today from the bottom. And somebody like Charisse, especially who's on the call, sees that on a regular basis because she works with smaller to medium-sized providers as well. So that's actually great advice. Don, you want to pick up some of the questions that you prepared now that we have a beautiful view on the back is kind of covering up your face, Doctor. So
still dark in Hawaii.
Yeah. Yeah, we got a black shadow for your face here.
Maybe that's better today, guys. I have a face for Twitter.
Oh, really? We'll let you. We'll let you say things that maybe you don't want to really let people know who it is. So we'll keep your face blackened, and you can say whatever you want.
I kind of feel like we're watching one of those 2020 interviews.
There we are.
Welcome, sir.
Thank you. Hey, sorry for the Hawaii delay today.
Hey, no worries. Glad you made it.
Yeah.
So yeah, we were just getting set up here and talking a little bit about the uptake of CCM into practice and what some of the doctors' perspectives were on that through Matt's eyes. I think it probably makes sense to double back just a second here and revisit that with you. What made you get interested in this and decide to take the plunge into chronic care management and try to figure it all out? And what do you think is preventing others from doing so?
The bottom line is, are you really engaged with your patients for understanding and trying to bend that curve? Right now in the United States, we have probably, depending on which state you look at, 5% of our population is consuming 50 to 60% of the healthcare GDP. So there's that cost factor, obviously, which is driving CMS. But when you look at a practicing physician, you realize that you spend so much time trying to help those patients, and their care is so complex that you have to find a different way to do it. And I think when you look at all these demonstration projects, that's what you're getting. You're getting different ways to try to engage your patients. So the CCM project is trying to really look at the physicians, give them an incentive to pay for a lot of that extra time. You have to understand, we've been spending this extra time with these patients for years and years. But I think CCM is trying to now let people know that we recognize that, we appreciate that, and they're going to try to pay patients or pay providers to do that. Remember, our staff spends so much time with our complex patients, scheduling their appointments, calling them for follow-ups, engaging them to see, if everything is okay. So I believe this is just one step of a group of complicated efforts across the country to help the primary care physicians, which I will say everybody knows we have been on the bottom of the feeding chain here, and we just work every day. But it's about engaging.
Mm-hmm. That's really interesting. So it's, from your perspective, at least, it's been more of a way to be compensated for work that you've already been doing. So with the uptake on the program being lower than CMS and others had hoped, are all of these other providers who are not participating, they're out there doing this work and not being compensated for it? Is it a lack of awareness that they could be, or is it a fear thing that they just don't want to get involved with one more system, one more regulation that they gotta keep track of?
I think it's a lack of awareness. I'm not sure what the last data point shows about how many people actually don't even realize this program is out there. So I think there's still a lack of awareness. I think it's a lack of systems. As you probably have heard from Matt, ChronicCareIQ, I think, creates a great system that you put in place that enables this. If you don't have a system in place, you have to think about doing this manually. Even with your EMR, there's usually not a functionality in the EMR that will allow you to collect the time and do the things necessary to be in compliance. I think most conscientious physicians are really concerned about being in compliance with the guidelines if they ever get audited. And so it's a combination of the compliance and a combination of the the startup. I definitely will tell you that the startup with explaining to the patients the problem, going over their care plan, explaining the quote-unquote contractual relationships, discussing the billing and fees, which is important for many people on fixed incomes. Those are a challenge, but once you get by it, you have to think the bigger picture. It's all about the patients. It's all about the usually very sick, complicated patients that gives you that greater engagement.
Yeah, that makes sense. And Scott, your voice was breaking just a bit, so if you want to get closer, or whatever you were doing before was fine. Just the last 30 seconds has been a little bit choppier, but we got it. Talk to us a little bit about workforce readiness. I mean, there is the ideal move over the next 10 years, CMS is proposing, is to increase value-based care. And I don't think anybody disagrees with that. It's a matter of how you do it and what are the techniques. Are your personnel, whether it's just the nurses or it might be administrative personnel, are they ready for that value-based care? And I think you've got good systems like Matt's here that are going to handle the technology side. What are you guys doing about the workforce, though? Do they understand this shift? Do they understand what those steps are and they just need a system to help them go through it? Or do they still need to be trained about what is value-based care? How do you engage with patients? What do you do about care coordination? Where does the workforce sit?
You hit this on the head, and what the problem is you have such a broad spectrum of awareness across the country, and our practice has been a level 3 primary care medical home. We were part of the 25 physicians in the state of Hawaii in 2009 that engaged in the medical home. We've been living and breathing this. So when you talk about if you were actively engaged in the medical home process, then we as a state have worked. Most people probably don't realize Hawaii is so far ahead of the rest of the country when it comes to value-based care. Right now my practice is one of 5 groups and about 300 physicians who have gone fully capitated for 50% of my entire practice. And that's with our largest carrier, Blue Cross Blue Shield. And that is just laced with value-based care incentives that was just a progress from the PCMH. And, so for us, this was simple to make the transition. A great team, a great staff, mid-levels are key. I think if we really want to be really effective with this, mid-levels will make a big difference. I have 5 PhDs practitioners. But the bottom line is, you've nailed it. There are people, remember, in Hawaii, for example, we only have 2/3 of our providers are on EMR. 1/3 aren't. I don't know how people do this without even being on EMR, let alone have their staff with systems in place to do this.
So can you repeat that? You said half of your payments are capitated at this point?
Yeah, half of my entire practice is capitated right now. 100% fully capitated.
And you're saying and you're saying that that's pretty normal for Hawaii?
Well, we're going to a point where in about 18 months, the entire state of Hawaii, the physicians with our largest carrier, which in general represents about 75% of the population, will be capitated.
Wow. Well, you guys are going to have to be, you're going to be forced to move much faster than you even wanted to. So all of this workforce prep work, and that's an area, Matt, from your perspective, when you and I initially chatted a couple of months back here in DC, there's the question of, is the tech there? Then there's the question of what services could you provide in addition to the tech? And then there's the question of how would you train Scott and his personnel to make sure that they can accommodate whatever the great technology is or whatever the great processes are. So those 3 things are quite different. And what we're seeing in the marketplace, and this is a really good advice to all of our innovators, especially that are watching, to figure out if you think your service is really, really good, if you think your technology is really, really good, then that means that your services have to be just as good, if not better. And knowing Matt for a long time, that's something that you've pressed on to your previous companies, and I'm sure you're doing the same here. But that last piece is really worrying me as I talk with lots of practices, and it doesn't matter whether you're a large health system or a small health system. When we say value-based care, when we say population health, care coordination, medical homes, the idea of patient engagement, I don't think any two organizations are defining it the same way, let alone implementing it or connecting it. And until, like even with EHR, as you remember, until the meaningful use definition established what an EHR was, when you said EHR, it could have meant almost anything in a variety of different segments. And so that, I think, is a problem as we go forward for CCM. It's a problem for CPC Plus and other areas. So that might be a good place to have our conversation. So Don, you want to jump in? You've got a couple of prepared questions for both Scott and Matt as well.
Yeah, absolutely. And I think starting to address, we laid out some of the hurdles that people face coming into this, and certainly from the system side, that's what you're going after here with ChronicCareIQ. So, Matt, how do you address some of these issues that have come up in terms of, how do you help the patients get enrolled? How do you help them keep track of minutes throughout the month? Walk us through your process and a practical standpoint, what the day looks like.
Sure. Well, and thanks for asking the question. I feel like when I look at providers and healthcare and how we're trying to change and accommodate and solve these problems, it strikes me that 99% of the activity is done by the healthcare providers. And until we can get patients more engaged, the people that are suffering these chronic conditions, et cetera, I think that there's only a limited amount of extra work that we can do, and we're reaching a point of diminishing marginal utility. So what ChronicCareIQ believes is that by prompting the patient to just update their doctor with a few simple points a day on their smartphone, they enable the clinical folks at the practice to trend those patients and get some idea of how they're doing. Because after all, it is chronic patients that consume 86% of the healthcare costs in America, and it's responsible for 7 out of 10 patient deaths. So number one, I think it's most important if we're going to really solve this challenge is that we connect patients back to their doctors and we let them do some of the heavy lifting. Instead of it being a constant pull from the doctor's side, it has to be more of a push from the patient side. And that has to be in a fashion that both sides can live with, easy for the patients, easy for the doctors. The way that we get the patients engaged, especially chronic patients, is we point out to them under no uncertain terms is that when your chronic disease is ignored and you're out of compliance with your chronic disease, your disease progresses. And it progresses over time in an accelerating rate until you reach the point where you require a tremendous amount of services just to keep you at par. And when a doctor gets trained to treat chronic disease, they go to school for years and they spend years of effort learning how to do it. When the patient is diagnosed with a chronic disease, and I am one, we get a pep talk and a couple prescriptions, and we don't really have a mechanism to let the doctor's staff mentor us in a fashion that works for everyone. So I really feel like it's about patient engagement, and the way that we engage the patient is help them understand what happens if they don't manage their chronic disease. And then we show them that they can take active steps to help their doctor help them in less than 20, 30 seconds a day.
Got it. And what's the response from the patients in terms of how many of them actually do this and every day will go in there and answer some questions and send some data to the doctor?
Sure. Our weekly response rates, and we only measure them weekly because we only prompt some patients once a week, are between 85 and 93% since the day we started enrolling patients. We get between 85 and 93% patient compliance. The primary driver of that is probably that we're enrolling the most sick patients, so they're scared and they're insecure and they're eager to adopt something that more closely attaches them, to their physician's office. We'll see as time goes on and we start enrolling more and more moderately controlled type 2 diabetics that don't want to be bothered so much, but right now we're having tremendous success.
That's pretty impressive. I would not have expected the numbers to be that high. So what types of questions are you asking them to feed into the practice?
It all depends on what the patient is diagnosed with. We have everything from complex liver patients to the standard ones that everybody worries about: hypertension, heart failure, and diabetes. That's probably a better question, or it's just as relevant to Dr. Miscovich. And like, what types of questions do your protocols have, Dr. Miscovich?
Yeah, thanks, Matt. The one thing I like about ChronicCareIQ too is we were able to develop our own custom protocols. And like, for example, you could take a condition like congestive heart failure. That's a big cause of admission, big cause of readmission, big cause of morbidity, big cause of patient deaths. And, like, one of the most sensitive factors that I try to teach a patient is when you have heart failure, you'll start to retain fluids. The fluids will be in your lungs. So, like, the early warning sign, oops, what happened here?
No, it's nothing you did.
Yeah,
Shah jumped out a little bit early.
Okay, the early warning sign will be patient will start retaining fluids, and fluids weigh a lot. So bottom line is you will then have a sudden increase in weight. So we actually, in conjunction with ChronicCareIQ, I actually invest, and I will give my patients who don't have a scale, I give them a scale to take. I've also invested in automated blood pressure cuffs. And so between the scale and a blood pressure cuff, it might be a little bit more than I'm going to get for 1 month of engagement, and I'm happy to invest in it. But for me, it's good quality. So I send my patients home with a blood pressure cuff and scale, and then on their ChronicCareIQ app, they have to enter their weight every day. They have to enter their blood pressure every day. And man, do they appreciate that. So it is an investment. I'm not saying every provider is going to go out and invest in that, but it really is a big difference. So questions like, you're in the mood. How do you feel today? You feel tired. You feel more fatigued. It's just like the worst patient feel. It engages them both emotionally, and it also engages them on parameters that for a practicing clinician are very important. That's what I love about the process. That you can also get the mood, get depression. So 50% of these people are going to have, the 50% of the people who would have a chronic disease will also have some sort of a mood disorder. So it engages all of those things.
Gotcha. Now, in making your own investment, do you think that because you're sitting in a situation where you are already 50% capitated, you've got the tool in place to do this, you're in a position where there's a lot of benefit to your practice, financially speaking, I would imagine, for doing a good job at this and for making that investment. Is that accurate? And if so, do you think that there's, outside of Hawaii where there's less capitation to date, that it's a little more difficult for folks to do it?
No, I think that I would definitely not see that all of the providers are going to invest and give the patients these tools. I know that's a bigger challenge, and many people, if they're listening, are probably saying, no way am I going to be buying scales for my patients. So I am in a more unique situation because I've been so engaged for such a long time in this preventative patient care. So do I feel that I'm in a better position? I'm in a better position because we engaged in prevention. We engaged in understanding that if you invest the time in these patients, now you're going to see outcome in the future. A practice will gain by your reputation. I mean, I think
Gotcha.
not gained by the families and the people who know I'm reaching out to their loved ones, their parents, their grandparents, to know that they have this app. The kids are coming in teaching the parents how to use the app. The kids are coming in and thanking me for saying, wow, they have a new insight into caring about their health. And so, the reward isn't purely financial, it's a global return on investment. I think it comes from many different ways than just the pure dollar or that CCM dollar.
Gotcha. That's a great way to look at it, and it is, the value, that word of mouth value, and keeping patients coming back is huge too, and a little harder to measure in some ways.
Exactly.
So, Matt, what is the two models out there were a full service model where someone would come in, they would take on your service, and then the outsourced call center, that whole nine, or a tool set that puts it into the doctor's hands, like Dr. Miscovich, and it just helps him and his staff to do this alone, more of kind of a hybrid, if you will. What is your model, and why did you decide on the one that you did?
Well, our model is really a tool set to provide to the physicians to make success with CCM achievable at the practice, within the practice, and not really service-based outsourcing. Did that for multiple reasons. My experience as a patient is I don't want someone I don't know calling me on the phone. Second thing is I'm a little weary because I have a pretty serious chronic disease, type 1 diabetes, meaning if you get too far outside of that, you don't have a big window to get fixed. You got to pay. You got to be pretty diligent about it. And so I really want trusted people providing me care, and I just felt like that much more encapsulates the level of care that most doctors that I've worked with in the past want to provide. They're more tied to the level of care, not necessarily, well, how can I shoulder off this work and still get paid? I don't believe that's in the heart of the American physician.
Got it. Excellent. And Dr. Miscovich, in terms of choosing your tool set, did you have a similar kind of mindset there, as that you wanted to keep that work in-house? You wanted your staff doing the outreach?
Wow, man, you just hit a hot nerve for me, because if I have one thing that is really, really problematic, is I think across the country, a lot of insurance carriers have outsourced this to bigger national companies and organizations that are, taking part of that healthcare dollar, and they have call centers, and they have all these different external devices, and they have supposedly are supposed to have care coordinators and nurses that deal with these patients. But there are some issues with that they can't overcome. Most of that is run on claims data. Claims data is old. By the time they get a patient engaged in the system, that patient could have 2 or 3 episodes. What I love about what Matt's product does, it's real time. You're getting this daily. You're reaching out every single day. So from the rest of my staff engagement, absolutely. I can't tell you how many times I had patients say to me, I got a call from this person, and I don't know who they are, and they're asking me all these personal questions, and they claim they're from an insurance company, or they claim they're from some other company, and they use a name, and I told them, call a doctor. So big issue for me, and it has to be personal. That's what the whole CMS push is going for now, to re-engage because let's face it, they've been doing that now. We've been paying insurance carriers across the country to do this, and it hasn't worked. We haven't controlled the cost of chronic care. It's been escalating. So we have to re-engage in some way to address these very complicated patients who are very sick, but also costing our country and our system enormously.
Yeah, absolutely. So what I'd like to kind of transition a little bit into the CPC Plus initiative. Dr. Miscovich, I know you're working on that in Hawaii. As of, I think it was August 1st, Hawaii's been named one of the 20 or so regions that are eligible for that. And you felt like that really tied in well to this conversation and to the even to the tool set that Matt's working on here. Why don't you tell us about what's going on in Hawaii, and how is the launch of CPC Plus initiative going to impact the way that you're managing chronic care from a practical day-to-day operation standpoint, but also from a financial standpoint? What's going to change?
For us, we were one of the regions selected, and as you see what's already happened in Hawaii, we're already in advance. So remember, for us, it's not going to be that much of a difference. It's going to only affect a smaller subset of my patients. Remember, CPC Plus is for plain Medicare. It's not for any of the Medicare Advantage patients. So those patients are, not included in the CPC Plus model. And, I think we have a fairly high saturation. I guess probably well over 50% of my patients on Medicare are in the CP or in a Medicare Advantage plan. So, it's such a natural flow. If you really look at what CPC Plus is doing, it is just another way to say, like if you look at track 1, that they want to pay doctors at an average about $15 per member. But the key, if you dig down into the details, is access. It's engagement. It's to get your practice to find ways with a little extra compensation to engage these people, to get them in, to talk about their chronic conditions, to try to prevent hospitalizations, to try to get 24/7 phone advice to the practice, not to an outpatient center. And it's try to, follow them up after hospitalizations, follow them up after complex illnesses. I mean, think about what we just talked about in chronic care CCM and with what Matt's product does. It's all of us. It's every single one of us. So this is just a natural extension of chronic care management. It's a natural extension of what, like the app and program is doing. Engagement at a physician to patient direct practice level.
Gotcha. And is it adding any work to the process? What you've already got in place with your CCM program. Are you going to have additional quality reporting, additional just other regulatory things to deal with as a part of CPC Plus?
No, I mean, I think we have way more requirements for some of the other programs we're in. Well, I don't want to say way more, but we have more requirements for the programs we're in. So from my standpoint, it's not going to really add that much more. We already systematically are doing all of the things that CPC Plus is asking. I probably could qualify for track 2, but I'm going to probably just stick with track 1 because it's a natural engagement for where we are right now.
Gotcha. And Matt, from your perspective, I know the CPC Plus program was looking to have vendors kind of sign on and with some form of attestation with their partners that they understood the program, they're going to support them for the long haul. What does that look like for you? Are you guys going down that path? Are you going to look to support CPC Plus? And if so, does that change anything from the technology standpoint?
Well, so we're definitely going to support it. And I want to be clear, I think that patient engagement, the evolution of the smartphone and the fact that it's now much easier for a patient to keep a practice updated, and it's much easier through that technology for the practice to be aware of the updates. I don't think chronic care has, the care of chronic patients has a path that doesn't involve patient engagement through technology. So without a doubt, that's the space we live in, and we're going to play a role in that. Over the next 5 years, I think there will be a lot of evolutions of what happens, in these programs. It's difficult to say. When we started in the EMR business, or I did, a decade ago, I never thought that the government would come out and say it's going to have to do this, 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 and this. So I'll need to understand what all of those commitments are, but without a doubt, and from the bottom of my heart as a chronic patient, we are going to be there to keep doctors and patients connected so that they can live better with their chronic disease and avoid, we call them episodes, but episode means a trip to the emergency room or getting hospitalized. And that's pretty traumatic, especially for the elderly. So that's where our company's heart is.
Gotcha. Very good. Yeah, and hopefully CMS learned some lessons, and once you learn some lessons through the the EHR stuff that you mentioned, and it didn't seem like, at least in some of the webinars that I sat on, that they were being too specific about what needed to happen. They were really, to me, it almost looked like they were asking for this almost unenforceable, but they just wanted to have somebody say kind of what you just said, is that we're doing this, we're in it. We understand the goals of the platform and, sign off on that. So it doesn't seem like it's something they could hold you accountable to. It's almost more ceremonial. And Dr. Miscovich, I assume you've been through all of that technology stuff that CMS put out. Is that about your take on it, or do you think there's something more to it than what I just described?
No, you're right on target. I think that, this is another way, you look, there are trying to engage 5,000 practices across the country, 1,500, I guess, could be in an ACO model. So this is an attempt to reach out. Here's one thing I found interesting in it. If we get more than 5,000 practices applying, they're not going to be doing it based on merit. They're basically going to be doing it and awarding it on lottery. Yeah. And so when you see that, you can tell that this is an approach to reach out to the common physicians across the country to give them an option to innovate. And so that's what I believe this is about. to say that we know it's going to cost. We have to invest in innovation. That's probably the biggest key of what we're seeing right now. Is the country realizes that we're not at the destination. We're on a very long path of transitioning healthcare, and to get there, you have to invest in innovation. And so when you see all these demonstration projects, that's what they're doing. And I think, they're going about it. I mean, look at there's 73 CMS demonstration projects going on right now. They're going to start. Why is it working? I believe that when we have successful programs out of this 5,000, they're going to dig deeper. Think, how are you doing it?
Right.
What's your key? That's what we all need to do.
Yep. Yeah, it really is. They're just trying to get people moving and get them trying stuff. And I generally like that approach. This came up during the tweet chat a little bit, and I love the iterative approach, and I love that we're taking some shots. And I think that when you start to look at a CPC plus in the CCM and ACOs and how the doctors can now be participating effectively in all of them, and it becomes very middling. So there's lots of different ways this is being done. Middling's not the right term, but it's kind of everyone's being pushed towards the same center, and something is going to evolve out of that. And if they do lay off on some of the really specific requirements about how technology needs to work and what some of those specifics are, hopefully we end up with something pretty good that a whole bunch of practitioners arrived at by doing exactly what you guys are doing in the real world. So I like it. But at the same time, it's like there's so many of them, it's hard to make any sense of it. And I'd like to get into that a little bit.
Can I make a comment about that, Don?
Yes, please.
One of the things I really like about this, you saw where we started out with like the Pioneer ACO projects very early on, and they had mixed results. And then as you always have, then you have different reiterations of evolving from that. And as it evolved in a system that has so much money in it, you saw a quick evolution to where the insurance companies, big health systems, big multi-hospital systems grabbed it and took it over. Mm-hmm. And that's what happened with a lot of the ACOs. So we were, I think, threatened that this innovation would then move towards, consolidation with big payers. The CCM project, I think, is now realizing that the care is delivered one-on-one. It's delivered in the physician's office. That's where it's effectively delivered. Yes, there has to be an overall umbrella, but I think that I really like the fact that CMS put this in place to reach out to the small and very, very mid-sized practices and did not make this for a large health system to come in and dominate it. So you have to realize that will always be essential and key to a legal system in the United States. It will be small practice, one. You close that exam room door, that's where the difference is made.
Yeah, I totally agree. And Matt, did you have any comments on that? Kind of scrolling up, I saw a question over here that I think kind of relates to through all of this regulation. So again, you got CCM, you got CPC plus, you got the ACOs kind of all interplaying. Somebody had a question over here earlier that I'm having trouble finding right now, was basically about shouldn't this type of management almost be a prerequisite moving into MIPS? So there's another thing kind of layered in there. Obviously, if you're in CPC plus, you don't have to do MIPS. If you're in an ACO, you might have to do MIPS. And if you're in neither and you're doing the chronic care management, you do. So it felt like it fit. What are your thoughts on that? Like from a doctor's perspective, how do you keep up with all this stuff? How do you make sense of it and make good decisions for your business?
Wow. I'm going to give you a bigger perspective that I have with this. And that perspective is that we have to, this is, again, it's an evolution. And if you look back at the history of CMS and what they've done, right now, they're strongly using the carrot. And the carrot is out there for everybody to say, we're going to pay for innovation, we're going to pay for change. But soon, as in most projects, when they get people to understand the carrot is only so long and you can only eat it so much, it's going to go to an incentive neutral program. And then as the hospitals now realize when it comes to like their readmissions and infections and failed like hips and things, they get hit with a stick. And so I call it healthcare Darwinism. And I think practices are either going to evolve or they're going to wither. And, you know, the thing that we are seeing is the evolutionary period of time is going to be more than ample to allow a practice to start to begin to evolve. And I think a physician and a practice is either going to start looking at the future and understanding evolution is necessary if you want to survive, or else they're going to unfortunately maybe jump ship, go to a hospital, go to a bigger group. And I'm not a supporter of that. I think we have to have across our country a strong and thriving independent practicability and not have a major consolidation.
Hey, Don, may I jump in and say something?
Absolutely, please do.
All right, so I want to just jump in and reinforce that Dr. Miscovich isn't just a provider in Hawaii with an opinion. He works closely with the governor and the state legislature on crafting some of these plans and how do we deal with our Medicaid populations and our chronic care populations. And he's been a level 3 patient-centered medical home for years. So at the policy level and at the practical level, he runs his practice, every day with multiple mid-level providers. And I just want to reinforce that statement, and that observation is that right now it's carrots, and then it moves to budget neutral, and then it's sticks. And so we will have winners, and unfortunately, there will be people that feel like they were a victim. And it's funny that you mentioned Darwinism this morning, because as I was thinking about this, I thought the exact same thing, that this is almost a Darwinistic move. But look, we've got to do better. We've got to find better means of getting better value out of our healthcare dollar. 20% of GDP in 10 years, unheard of. I mean, it all ends with better public health spending and better awareness, et cetera. But we've got this middle ground to traverse, and that is 10,000 baby boomers a day, and 70% of them have 2 or more chronic diseases, and the place that they're getting treatment is in the most expensive places in the country. It's in the hospital or the ED. So we've got to solve that problem on the path to solving the other problems. And it's a journey and it's an evolution. But by hook or crook, the evolution's coming.
Yeah, I agree 100%.
One of the things I want to add is that you also combine that with a tremendous physician shortage. We combine that with across the country, the data shows that it's worse in primary care. So as you get the hold on a second, I got a little technical issue here. As you get these baby boomers moving on and you get the population increasing as the primary care physician shortage, you're going to have to engage physician extenders, but you're going to have to engage technology. You're going to have to engage things that make reaching out easier. I mean, if we could just throw people at this, well, maybe we could help solve this, but we can't. We're having those curves go in the opposite direction. And so that's why I believe technology and efficiency, and that's what I like about ChronicCareIQ as well as what we're doing in our office, are part of the keys.
Yeah, no, I think you're right on. And last week our topic was patient-generated health data, and ultimately how does it play into the this type of thing? How do you engage the patient on a regular basis to help them to largely manage their collection of their data and their care outside of those visits? And then what do you do with all of it? And that's where the technology comes in. And it's, what can we do with whether it's AI or machine learning or whatever other term, but basically what can we do with a software platform that can narrow down the things that need to bubble up to a physician like you and, deal with that. How does that play into us helping us deal with the physician shortage and certainly the cost aspect of all of this? So it's,
Dawn, I'm sorry to jump in, but this is an important think we didn't talk about. Like, I'm using Matt's platform. I wish we could throw a graphic up of what the dashboard looks like. And we can have a person sitting at a dashboard that has an active real-time graph of all the patients, shows their numbers, and it shows what patients are reaching up to a threshold that we feel starts to show that their healthcare needs immediate attention, and we can reach out to them. And when you look at that, to have all of your data, and I know we use this cliche of population health. Well, population health is important, but it can't be just this big at the end of the year. Let's start collecting some data and try to analyze who's sick. It's now. Those patients need action now. Those patients, we may have a window of 48 hours where we need to intervene. So we have Matt's dashboard up, and we see what those scores are. And then we see, like, for example, if a couple of patients who are really close to that threshold all of a sudden haven't checked in 2 days, guess what? We're on the phone with them. We're calling them, engaging them back. That's, healthcare in that sick population is a now real-time interactive piece of data that's not a long-term claims-based population health data analysis.
Yeah, right on. No, and it's funny. I didn't when I scheduled these 2 shows back to back, I didn't even piece together how much they would run into each other. But that's effectively what you're doing is you're collecting a bunch of patient-generated health data, and you're putting it through a system that's helping you make sense of it and calling out the things that need your attention. And that's definitely a great way to deal with both that shortage problem and the money problem.
Yeah, there's another piece that I'm really excited about because I do some clinical research on a small scale that's real just patient outcome driven, and I'm excited to look at what now I can do with this data, and I could generate my own outcome data to say, well, how effective, like if I ask a question of, say, what is the change in your daily weight over time, and how sensitive is that as a predictor of congestive heart failure in this group? Or when I combine that with the average change in their blood pressure and perhaps their mood opinion, well, I don't feel really good. Am I going to be able to create my own little practice-generated data to say, when I see those 3 combinations, that may even be the earlier warning sign that something is changing. So to put that right in everybody's hands is very exciting for me.
Yeah, I agree. And that becomes a rule in the engine to help that guy bubble up to the top. Yep.
And that's cool. A huge piece of where the company's going as well. And I would add this for you, Dr. Miscovich, if you're getting some questions, you're getting some signs, and then when that information comes in, to be able to throw in a question that says, maybe this week, have you had more good days or bad days? And we can start sensing maybe bordering on some depression so that you can more quickly intervene before that patient kind of just gets the feeling down and stops trying their exercise plan and stops trying to be compliant. There's so much we don't know yet, but we're learning. And I think it's going to be a new science, and it's going to show us a lot.
Yeah, what I really like about what you guys just described too is that you're going to use the data that is kind of runoff from a process that you're accomplishing something with to then do the population health. And it's what I see too often is the idea of, and it's kind of what you just described, but it's like, well, we need to collect the data. It's which data? Well, we want all of the data because we don't know what we need. We don't know what we're actually trying to accomplish. And then that need to have all of the data is the thing that makes none of the data flow. So you guys are you're attacking a very specific problem, and you're collecting the data to solve that problem, and then talking about how do you use that, data runoff as an asset itself. And I love that. It's it's a much more efficient way to innovate than to kind of just get everything in a pile and hope you find an answer.
Simultaneously, we're doing that at a scale that is meaningful to the profitability for the reimbursements that we automate. So it all goes back to Medicare's reimbursement for the initiative. It makes it worth the physician's while to do it, or at least it monetizes the practice. I think, physicians want to give the best care they can, and now they can be reimbursed for it at the same time. I think that that's important, very important piece.
Absolutely.
It's a bottom-up data analysis versus a top-down. And, you've had so many companies rushing in to get into the population health data analysis and population health metrics and things. So let's face it, how is research done? We all know that. You take most of the research we're all seeing is data that is 4 or 5 years old that someone chews on for about 12 to 24 months and then runs it through a bunch of other analytics. And eventually about 3 to 4 years after it's done, they spit it out and they try to make conclusions from it. That's what population health data really is. We want real-time data. As practicing clinicians, this gives us the opportunity to do both. It gives us a ability to connect with longitudinal data over time while we're actively working on it half day, 1 day, 2 days at a time, and we can interact with our patients. So it's a much better approach.
Got it. Very good. Awesome. Well, we are just at our time here at 1:30. So I'm going to go ahead and wrap it up, but, just give you those sounded like good closing comments. Do you either have anything else you wanted to add?
Well, I just want to thank Dr. Miscovich. He's a rock star in chronic disease management, been doing it a long time, and it's an honor to have you aboard, and keep up the dialogue. Whatever you need, we deliver.
Yeah. And thank you, Dawn and Matt, too. It's been a pleasure working with his organization. I have to just say this. The product that we have now with Matt, we have some little signs up in our waiting room right now, and it talks about, here's what the product is. Every single day, we've just opened up to our entire population, because I believe chronic care management, projects like ChronicCareIQ, CPC Plus, are soon going to be involved in every aspect of every payer, of every patient in the United States. This is here to stay. We're in an evolutionary process. Social media is so important, and it is going to grab a lot of people. And so we're using Match product now for people we don't get paid for, because it is a great engagement tool. It doesn't take a lot of extra time because the patients are involving that and putting the data in themselves. We're sitting there watching it and interacting. So I just can't say enough about where this is going. I'm pleased with where Chronic Care Plus and CMS is going, and great working with Matt and Dawn. Thank you.
Yeah, awesome. And that is, that's just music to the ears that you're able to implement this independent of a government incentive on those other patients. I think that's awesome. That's got to be an indicator that we're on the right track. So kudos to both of you. Thank you so much for coming. It's been really informative. I really enjoyed talking with both of you. And let's stay in touch. Maybe we can do this again once CPC Plus is up and running.
Sounds good.
Awesome. Thanks, guys. Have a great day.
Thank you.
Hey, guys.
Thank you.
Thanks. Bye.